so.
That's okay. As long as she can hear you.
All right. Do I have to share
And you have to
content?
share.
Yeah. So much sharing going on. This one?
That one.
All right.
And now you're good.
Easy.
And if she texts us that she can't hear, we will tell you.
All right.
Thanks, guys. It's good. I can see
I
and
can
hear.
hear her.
It looks good.
I usually speak loudly enough that you can hear me and a calorie, regardless of whether video conferencing is involved. All right. All right, we're gonna get started because it's 2, and I don't have that much to talk about. So hi, my name is Matt Speckert. I'm gonna talk to you about acute leukemias for an hour, and then you will never need to know anything about this again. No, the really just wants you to know acute leukemias. That's all it says in the competencies. It's acute leukemias, approaches to. So with that in mind, I kind of tried to, when I was putting this together, I did what I normally do, which is I spend 80% of the time I have thinking about it and not doing anything, and then 20% of the time madly putting slides together, which I finished 15 minutes ago. So in advance, I apologize if there are inconsistencies. Broadly speaking, we're going to cover this. What I'd like you to be able to do after this talk is at least kind of have an idea of like, what do I do next? Have an idea of like, okay, you know, when should I really worry that somebody has leukemia versus just the radiologist told me to call you, so I'm calling you. And I've tried not to frame this in terms of your residency because from my perspective, like you've got 4 years of working here, you have brief periods of time where you get to work in other places, but here is not real life for most of you. Most of you are going to work somewhere else. A lot of you are going to work in the community, and it's different. It's different in different academic hospitals, the way that work is divided, and it's very different in the community, which you will learn or have learned in your North Bay rotations, if you do those still, in Iqaluit, if you're going. This is briefly about me, just so you know what I am coming to you with. I am from the GTA. I studied in med school in Toronto. I did my residency in Thunder Bay, which if you get it mixed up with North Bay, that's fair. It's up here where the little kayak guy is. And we are, yes, you can see a cursor. We are over here with the Parliament building. So it is kind of compressed on this map, but it is far away. If you were to drive there, Bruce is nodding, if you were to drive there from here, it would probably take you 15 hours of solid driving, not including breaks. The picture on the left is kind of what's inside me, and this is in Newfoundland. So I locum in a few different pediatric academic hospitals, and it's always hospitalist hematology oncology. So I don't do any general pediatrics, which means I don't actually know what you need to know about this. And so if something is not making sense to you, you're allowed to interrupt. Okay, if I wrote something on the slides that you're like, wait, that doesn't make, just stop me and ask. So I started with a series of questions. How do I recognize this? So I have the perspective of being called about this frequently by a variety of different providers. And so I thought maybe a good way to start would be take you out of CHEO and say, all right, you're the on-call pediatrician in a community hospital. It can be Northern Ontario, it can be Kitchener, Waterloo, wherever you want to put yourself in your head. And you get a call for advice from somebody in the community. It can be a family doctor, an NP, and they say, okay, I've got this 3-year-old. I saw him in my clinic. I noticed on his child exam that he's got big lymph nodes in his neck. I don't know, they're big. I don't have an ultrasound. He seems fine, like he's growing. He had a cold recently. I don't really feel a big spleen or a big liver. So what should I do? Should I send him to emerge? And that is a call you will get. And so what I'd like, and I kind of thought of putting together like a cell phone based poll, but it just that ends up taking a long time. So like, I don't know, I'm just gonna call people out who are looking at their computers. If you're looking at your computers, I'm gonna assume you're doing something important. I'm not gonna ask you questions. If you're looking at me, I'm gonna assume you're open to being asked questions. So take out your computers now. You're sitting in front of me. Just take, what's your name?
I'm Yada. I'm not.
Yada. Okay, I'm not gonna do well. What do you think? Emerge? Not emerge.
Maybe not emergency.
All right. All right. Okay. Somebody else weigh in. Do you agree? Do you disagree? Go ahead.
I think a little different. It's about what they're doing.
They're big. There are a few of them there. You're not going to get much on the phone, and this is the uncomfortable part. Is they're going to be like, I felt their neck. I don't know. They feel like, I don't know. They're not hurting. They're big-ish. Maybe 1 to 2 centimeters. I'm not really sure. And based on that, you're going to have to make a plan. So what kind of plan might you make with that information? Okay. What do you mean by a follow-up?
Like I would be like, come back when they see that you're still feeling those bigger or the same.
Love it. There is not a right answer to this question. There are going to be people who are like, fuck that. I'm not going to tell you not to go to emerge. Go to emerge. I don't trust anyone. You may become one of those people. And if you are, that's okay. The system functions. It is inconvenient. And sometimes you're going to have to factor in how far does that person need to go to get to an emergency department to get an ultrasound. So that somebody can ultrasound these lymph nodes and be like, looks like reactive lymph node. For me, I would say follow up. I would say follow up 2 weeks, do an exam. But realistically, these might be around for a while, and we'll get to that. So there is actually a study that looked at studies reporting leukemia symptoms. So they took all the studies they could find of cohorts of children that have leukemia that describe their symptoms, and they did a meta-analysis. They basically said, what are the symptoms that these studies are noticing in kids that are presenting with leukemia? And so if you look at the screen, I've listed 5 symptoms on the left. The top 2 tend to go together. There are stats beside them. That's the frequency of these things being there at presentation. In this study, they weren't able to separate it out how you like these things go in combinations. You kind of have to use your imagination a little bit. But if you are wondering, like, what are the things that most kids that present with leukemia are going to have, those 5 on the left-hand side are going to be that. You are most likely to see somebody who's got hepatosplenomegaly, pallor, losing, a fever. If you have none of those things, doesn't mean they don't have leukemia. But it's pretty reasonable to say, I don't really think it's because of that. Let's do a follow-up, or think of other causes, right? If you see somebody who has like fever, weight loss, hepatosplenomegaly, lymphadenopathy, bruise, like, this is a different situation. I am never going to be able to give you a talk that like gives you the exact, because the bottom line is you won't see it that often, and you will miss it. It's going to get missed. There are, like, in the last, I don't know, how long have I been here? 8 years doing this. Like, I can point you to cases where it's like they came to emerge with like belly pain. They were treated for constipation. They went home. They came back. Their white blood cell count is That's not the emerge doc's fault. Your job is to give good advice and do a physical exam for the problem they came in with. And this is why the Lord gave us discharge instructions. Okay? Reasons to come back. One of the things I want to point out on the page, lymphadenopathy, not that common. You'd think it would be there all the time. It's there maybe 40% of the time. Things that are commonly confused with other diagnoses are joint pain. So not everybody knows that like if you're looking at a cohort of kids with leukemia, like something that happens maybe in a third to, what do they have on here for joint pain? Limb and joint pain is common. Okay, for me, I'm like, 20%, 30% will come in with limb and joint pain. The first kid I remember having leukemia, I was in med school at Sick Kids on their short stay unit, and they were investigating a kid for systemic onset JIA. And it was like a whole week of like rheumatology testing, and then he went for a bone marrow because he was going to start steroids. I remember none of the details of this other than that. And then on Friday afternoon, the end of the week, I came and he's being wheeled down the hallway. And I was like, where's he going? And they're like, oh, he's going to oncology. He has leukemia. And so there are situations where you're going to be following a reasonable differential diagnosis. And then this is going to show up. Okay. Your job is not, your job is to find out what's causing sick things, like the sick thing. Your job is to figure out why the person in front of you is sick, not jump to conclusions. And on that note, 6% will be completely asymptomatic at presentation. So observe that. Okay, here are some cases. What do these cases have in common? So a 10-year-old with autism spectrum disorder, fairly severe, weight loss, refusing to walk, and on MRI, bilateral signal abnormalities in both femurs and pelvis. They say it could be CRMO, could be a lymphoproliferative leukemia problem. A 16-year-old with firm, non-tender bilateral cervical lymphadenopathy referred by ID who have ruled out infection. Those aren't passive-aggressive quotes, it's just because testing was pending. They are a little bit passive-aggressive. A 2-year-old with pallor, bruising, and marked pancytopenia. So what do these cases have in common? Heidi, did they all have leukemia or did none of them have leukemia? I don't care if you get this right.
Well, they all have like completely unwell.
Yeah, which one? A or B? You just pick. You don't have to read them. There's no reason.
Okay.
A? They all have leukemia? Okay. None of them have leukemia. None of those kids. Those are real kids and none of them have leukemia. Okay, number one, this is the kid I was handed over when I was on service. The overnight oncologist was like, there are 2 kids, they need bone marrows. One of them is this kid with autism. He hasn't walking. He's got marrow signal. He needs a bone marrow. He had scurvy. He had scurvy. This is when I met Mackenzie Simpson. I was there. I was like, okay, from my perspective, if you call me with the radiologist told us to do a bone marrow because they haven't, I'll just do the bone marrow. So this is an example where Dr. Simpson actually called me off. And she was like, no, I think they don't need a bone marrow, which is really important, okay? Because I don't think everybody would have done that. I think a lot of people would have been like, well, we got to rule it, right? You don't have to rule it out, okay? You have to diagnose the problem, okay? If you have a better diagnosis in mind, like this will keep. If it's leukemia, it will be leukemia when you follow them up, which is why you follow up, okay? Which is hard sometimes to do at this hospital because you don't have like an outpatient clinic you can easily bring them back. It's discharged to family doctor. This kid, EBV, mono, this is in Kingston. Their ID was like, I have never felt EBV like this. This is 100% cancer. Like I am confident. I was like, all right, Robin Clinic, EBV. The 2-year-old pallid bruising and marked pancytopenia. Zach, you want to take a stab? Yeah, aplastic anemia. Okay, shows up, looks just like cancer, except there are no blasts. Arguably worse than having cancer. Okay, so none of these kids have leukemia. And I am going to proceed faster, because otherwise we're going to talk. Leukemia is a rare diagnosis. Calibrate your brains accordingly. For the Emily and a calendar pointing at the bottom of the slide, in 2022, in the entire country, 200 kids were diagnosed with leukemia. That includes ALL and AML. 200 kids in a country of 30 million people with, I don't know how many million kids. It's not a common diagnosis. So the radiologist told me to should not be the reason you're consulting. It should be, I think this could actually be what this person has. And 6% are asymptomatic at presentation, which is not reassuring to hear. But the reason I'm telling you this is because you will miss it. It's okay. All right. It's not wrong to miss this. I tell this to patients when they're diagnosed and they're like, I saw my family doctor twice. What the hell? You're not supposed to think leukemia when somebody comes with belly pain. Has anybody seen this already? Yeah, one person has seen this. I'm gonna play it. It's incredibly offensive if you're a doctor in Canada. I'm gonna play it. I don't know if the sound will work. I don't know. Does this have speakers? The computer has speakers, but you're not gonna be able to hear it, are you? Okay, I'm gonna stay very quiet. It's turned up. Doesn't have sound. There's no sound. Fuck it. Watch it on your own time. It's so good, but it doesn't have sound. How do I make sound happen? Okay. All right, we'll go to YouTube, youtube.com.
So funny. And I'm like, I hope you guys laugh.
All right. I first heard about this. Oh God, Emily, I'm so sorry. Hold on. We're gonna share a screen with. Hold on. Just hold on a sec. This will work.
No, I can
You
see
see
it. It's
it?
working. Yeah.
All right, fair. Wait, you don't see it. Oh, sorry. People here don't see it. Okay, we're gonna share this tab instead. Oh, they have. Now the sound's gone. Oh, it's because it probably switched to this thing. Does this thing have sound? Hold on. Maybe?
The HBO problem.
Still have time to grieve my dead friend.
Hey, you got time to grieve, you got time to train the new doctor.
Hi, I'm Alex. I just graduated med school in America and I hate to set up life. Is that really an issue?
Just do as I do. Welcome to the pack. How we doing, sir?
It's like I'm on fire.
What am I looking at here?
You went around this thing here for 12 hours of cardiac arrest.
Okay, Glenn, I'm gonna write you a referral, okay? You're gonna need to see a specialist. You take this, write it to them, okay?
I think you just read the referral.
It's Canada. That's all we do. All right, who's this?
Jackie Reynolds, car accident.
Okay, Becky. Becky, are you with me? All right, this is for a life raft. They need you to get some tests done. Take that to them.
Wait, so everyone who comes in gets sent somewhere else?
And it doesn't get any damn easier.
You doctors and your demons.
We got another one. What happened? Fireworks accident downtown. They're sending out into this hospital. Okay, we're gonna need a bigger hallway. There's no.
I need 20 cc's of ink and 8 milligrams of paper and something hard to write on like a clipboard or a hardcover book.
All right, this is a referral for an ENT. You're gonna phone them. They're not gonna pick up, but they usually call back. Well, those all 62 pages of one stock. Hear me.
I'm not ready to be a doctor.
Look at me. Can you write your name and a phone number?
Yes.
Then you're a good enough doctor for Canada. No referral. You got this.
This is for an orthopedic surgeon. You're gonna have to go out of province. And this is a referral for an MRI. Come back in a year.
She's good.
This is for physio. I can tell you need it.
Very good.
62 referrals, the new record.
Did you ever think maybe we should put everyone in the hallway?
You got a lot to learn, rookie. Look, hey, coming to a hospital near you.
Okay.
Unfortunately.
Half of you are wildly offended, and the other half of you thought that was funny, and that's okay. Now my job is to get back to my presentation without. Okay, share this tab instead. Emily, are you seeing this?
No, not yet.
Or you can't see my presentation? Okay, no problem. I will get rid of that now, and we will go to Teams, and we will share screen window. Like, there we go. Now, how
Yeah,
are we doing?
Looks
Great.
good.
Okay, so I just told you about all the people who don't have cancer. Aren't some people predisposed to this? Shouldn't I think about this more with some people? Yes, there are some. Wow, since I did Gen Pizza, I can describe any of the features of this kid. Just look at it. Any guesses? syndrome. That's what the non-genetics resident people. So Sarah, what is it? It's okay if you don't know. You can just say I don't know. I don't know. Joey. Wait, somebody shout it out. Noonan's, yeah, Noonan's. Noonan's. Noonan's is one of those syndromes where I walk around sometimes and I'm like, you have Noonan's? Not in Twitter. JMML, very, very rare. It happens with Noonan's. This is not a remember this for your exam. This is hey, this syndrome you might have seen in other areas also is a cancer syndrome. Rarely. Also kids with NF1, JMML. We're not going to talk about JMML because it's too rare. What about this? Yeah, okay. This, I would say, reasonable to know. It is reasonable to know because there's a NICU connection. Does anybody know what transient myeloproliferative disorder is? Happens in NICU babies that you don't necessarily know have Down syndrome. Not necessarily, it's transient, so not necessarily a leukemia that you're going to treat. But in kids that have this, they're at, I forget what the risk is, like they have a lifelong increased risk of having leukemia later in life. So occasionally, and you probably have met some of our very adorable children with Down syndrome on 4 North who are getting treatment for ALL. Most of our patients have had ALL. We haven't had a myeloid leukemia of Down syndrome recently. That's worth knowing because they tend to do way better than other people with AML. Anybody? Kind of weird. But this kid is classic. This is a classic textbook picture kid. Fanconi. So this is Fanconi. Don't worry if you don't know this. This is Fanconi. This is the Fanconi kid. There's kids that just their pictures permeate the internet and they are emblematic. There's the Burkitt's lymphoma kid, and then there's Fanconi kid. So the things they're pointing out here is the Fanconi anemia. They're not always, but sometimes abnormal thumbs. They're short stature. There's facial features. They are a cancer predisposition syndrome. Roughly 1 in 10. They would be followed probably in a hematology clinic. And then there's a longer list. Don't remember it. This is just to kind of highlight the fact that there are a number of inherited predisposition syndromes. They fall into different categories. Probably the category to remember are the bone marrow failure syndromes because they overlap a lot with other areas, like things like Schwachman-Diamond you will encounter in other areas, pediatrics. You might see kids with Fanconi because they have short stature. DKC, dyskeratosis congenita. AML is probably less common than aplastic anemia in those patients. You'll probably see more of them if you're going to see them with aplastic anemia, but don't remember all of these. You don't even need to know this for an exam. This is not a reasonable thing to know. Know that there are bone marrow failure syndromes and that those are associated with leukemia. So how do I actually investigate somebody with leukemia? So now you are in the same hospital, same community pediatric setting, and the emerge doc has called you and they said, okay, a kid that you referred to the hospital is here now. This time it's a kid they called you about with like fever, pallor, bruising, hepatosplenomegaly, weight loss, everything. They're going to do some blood work and they want to make sure they get it all in one go. So what should they order? Brittany. Sorry, you're looking at your computer. I know I said I wouldn't. Okay, it's CBC good. Yeah. What else? In this situation, we're saying high pretest probability. Okay. Okay, louder, so everybody can hear you. Emily can't hear you in a color. Big category. So you want a CBC because you want to know if there are blasts. You want to know if there's pancytopenia. The rest is kind of, you want to know how bad it is. So tumor lysis blood work, we said lights, standard lights for the phosphate, uric acid, creatinine. LDH is because you want to know how bad it is. So LDH is a marker of cell turnover. Doesn't mean you have tumor lysis syndrome, just means there's cell turnover. It's also not specific to cancer. So you can have a high LDH if you have hemolytic anemia. So if you have a high LDH, it doesn't mean they have cancer. Let's see what I said. Screening investigations, I think, are reasonable for cancer when you think it's cancer. So this is not the same as like your workup for lymphadenopathy. This is you want to rule out cancer as a cause. Understanding you can't actually do that with blood work, you want to make it less likely. So CBC looking for pancytopenia blasts or atypical lymphocytes, which is what people say when they don't want to commit to writing blasts. Also, a term that is being phased out was classically associated with what infection? Anybody? Mono. Atypical lymphocytes used to be the way the pathologists would be like, I think your kid has mono. We're not going to go into what makes a blast and what makes an atypical lymphocyte because these are morphologic features. They are based on vibes under the microscope. They're not based on like anything you can objectively point to. It's just like looks kind of reactive. You might hear reactive lymphocytes too. What I'm trying not to do is make you think anytime you hear somebody say reactive lymphocytes or anytime you hear somebody say atypical lymphocytes, you're like, are they actually blasts? But when you are doing blood work for somebody you think has cancer and you see that, it doesn't necessarily mean there aren't blasts there. It might mean that there are very few of them, and the person doing the smear doesn't want to call it blast because as soon as you call it blast, somebody can be like, you have leukemia. Tumor lysis blood work. I feel like there was more in that. LDH and uric acid, extended electrolytes, creatinine, a coagulation profile. In some types of AML, you get DIC, and it's characteristic of a certain type of AML that's an emergency. So this is information that I would want. Okay, if you were calling me and you're like, I think this person has leukemia, the fibrinogen is 0.8. That would make me think this person has a specific type of AML that we treat on like morphology. We don't wait for the testing. We bring people in overnight to treat it because it's a very, very easily treated type of AML, very good outcomes. But the biggest risk is in like the early period where you can bleed into your head. So that's called acute promyelocytic leukemia, which in adults they call APL. Here we call APML. And then you always want to do a chest x-ray if you're thinking somebody has leukemia because you want to know if they have a leukocyte. Questions about that? It's not comprehensive. It's not every test you would order if you saw somebody with a fever. It's very focused to you are thinking somebody might have leukemia. You want to grab relevant blood work. Zach knows there are like virology testing and stuff like that. We said that's not within what I think you should order. Okay, that's second line blood work once you've established a diagnosis. A slide on lymphadenopathy. Lymph nodes aren't always cancer. I know you know this. Sometimes when you do an ultrasound, a radiologist will say, oh, this is a big lymph node. I'm not fatty hilum is gone. You must think about a leukemia or lymphoma. The radiologist told me to is not a valid consult. It should be rooted in actual history and physical exam stuff. So the most common cause of lymphadenopathy is an infection. So you should think infections. I've listed infections there. We recently had a kid with lymphadenopathy, turned out to have TB. It happens like maybe once a year where we have this, somebody comes in, they're like, TB or TB, it's TB. So again, infections are the most common cause of lymphadenopathy. If you're not thinking it's an infection, very reasonable. You've got blood work pending for it, but you're like, there's no good reason why this would be an infection. Then indications for a lymph node biopsy are really big lymph nodes, so usually larger than 2.5 centimeters. Supraclavicular lymph nodes, which when I was in med school was like gastric cancer. For pediatrics, it's Hodgkin's lymphoma. Like that's the group that's going to have big supraclavicular lymph nodes. I think also it's just a weird place to have a lymph node that's big. Like neck, maybe it's like close to your pharynx. This is not really close to things. I don't know. I'm making that up. obviously systemic symptoms, and then chronic, persistent, progressive. So you have a well kid, they have a big lymph node, it's getting bigger over time, they're still well, you're like, they have nothing else, but it's big and it's been there for 6 months. That's a reason why we can refer them for a biopsy. Questions about that? Good question. That falls into the category of what hospital you work in and who does what. In some hospitals, like neck biopsies are ENT, in other hospitals, neck biopsies are general surgery. So you send it to whatever surgery clinic in your hospital does this, and if you send it to ENT, odds are they'll do it. Like, they're not going to be like, no, we don't see that. But this is something that is hospital specific. That being said, you don't need to be an ENT to biopsy a supraclavicular lymph node. That's commonly done by gen surg here. Okay, you review the CBC, which has been resulted. The white count is 18, the hemoglobin is 34, the platelets are 15. That's not good. Neutrophils are 0.3, lymphocytes are 3, blasts are 15. What do you tell the family? A, this is leukemia and a bone marrow is needed to confirm the diagnosis. Or B, this could be leukemia and a bone marrow is needed to establish the diagnosis. Emily! You didn't think you were going to get called. She's gone.
No, I'm here. I'm just
Hey,
saying.
what do you think?
I think I want, as a general pediatrician, a bone marrow before telling the family, but I think you actually could, with blasts and bicytopenia, tell them pretty certainly that this is leukemia.
Okay. So you're B. You're B.
I'm B with the caveat that I actually believe in my heart it's A, but I would not feel comfortable doing that.
I really admire your honesty. I think it's probably reflective of how most people feel, because we are more afraid of saying something that's wrong than walking back something, saying something that's wrong and then having to walk it back, than not telling somebody something and then telling them later. And so that is admirable, except that is the scenario where you have the kid in Thunder Bay who ends up referred to like London, Ontario, and they don't know why they're referred there. And so I honestly think both of these are reasonable answers as long as you use the word leukemia. Okay. What I think is not reasonable is to be like, well, we're not really sure what's going on, and like, oh, the cell counts are low, and we're going to send you to a other place for a referral, and they're going to do some tests. Goodbye. Because realistically speaking, if you have a white count of 18 and somebody has called 15 out of 18 of those blasts, that's 80% blast. There's nothing else this is. This is leukemia. We would confirm the diagnosis, so technically B is right, even though I said A is right, with a bone marrow, either way. But I think you need to use the word cancer, you need to use the word leukemia, and whatever word you put before that is fine. You can say this is, you can say this is most likely, you could say I'm really worried about this being the cause, I'm pretty sure that this is. I often say when I'm not 100% sure and I'm waiting for more tests, is I can't imagine what else this would be. And that is enough for most people to be like, okay, like we're going to confirm it, but I can't think of anything else that would cause this. Okay, here's another situation where I forgot to animate the circle. The white count is now 1.8, same hemoglobin and platelets. The blasts are now 0.1. This is a situation where I'm much more wishy-washy. It's not wishy-washy. I'm much more careful, because low white count leukemia is harder to prove. Easy when it's like a white count of 100. There's not a lot of other things that do that, even ignoring whether or not there are blasts. White count over 100, I can't think of many things other than maybe pertussis that will do that. When you have low white count leukemia, I tell people this is very abnormal. I think this is most likely leukemia. We need to do a bone marrow to find out. Because these can sometimes be aplastic anemias. That's not a good thing. But you do a bone marrow in this kid, and it comes back looking like this. What are these? They're blasts. They're blasts. Okay, I don't have a normal lymphocyte for you on there. Those are all blasts. very briefly, you don't need to know this as a general pediatrician, or the non-hematologist. A blast is defined by being big, typically compared to a red blood cell, bigger. A normal lymphocyte is a red blood cell size. Being mostly nucleus because they're constantly dividing, uncontrolled cell division. So all of their chromatin are like unraveled and taking up a lot of space. So the ratio of nucleus to cytoplasm is high, a lot of nucleus. And then the nucleus is not dark purple, it's like pale pink. And that's again because all the chromatin are unraveled and dividing. That's a blast. So when I'm reading a blood smear and I say there are blasts there, this is what I'm talking about. A bone marrow is to do two things. An aspirate, which is basically taking blood from your bone marrow, which is the factory where you make blood, and often taking a core biopsy sample. For those of you that have done procedure room days where you've seen bone marrows, this is done with a big needle in your hip while you're asleep, and that's what I tell families. This is done with a big needle in your hip while you're asleep. After you get this procedure done, it's your iliac crest. It's not involved in walking, so like there is no, like when I can send people for this, I say infection. That's about it. Bleeding is not a major concern, although we did have one kid with like an arterial, like a gluteal artery bleed that I don't really know how it happened, but that's one in like 10 years. But yeah, skin infection, that's about it. The way that we diagnose leukemia is we look to see if there are blasts. If we see that there are blasts there, we say this is leukemia. But that is not specific, as you know, there are different kinds of leukemia. So that's where flow cytometry comes in. And while I was biking over here, I was reflecting on the fact that I'm like, I don't know how we proved that flow cytometry. Like, how do you tell that these are the cells that we say they are? I don't know. I don't get it. But basically, it is a tube that you run cells through one at a time and you shine lights at them, and that helps tell you what they are. I don't know how. It's based on how big they are. And it's based on these probes on the surface of the cell that somehow we've like clustered them together. But that's all you need to know is there's a test. It's called flow cytometry. We do it on blood, bone marrow, and CSF, and it tells us what kind of cells are there. And when we're looking at blasts, it tells us what kind of blasts they are. Every good hematology talk needs to have this slide. I'm sorry. There are different lineages. They can all have leukemia in them. They can have leukemia at different stages. Some of the leukemias only happen in adults, so like you don't really see like eosinophilic leukemias in kids, but you can see them in adults. And then the vast majority of what you're going to see if you see leukemia are going to be ALL, which is in blue, which is like 3 out of every 4 leukemia cases are going to be ALL, whether it be a B cell or a T cell. 85% of the time, it's going to be a B cell. So the vast majority of leukemias are B cell leukemias. The other 25% are AML, and then other stuff, rare leukemias, Burkitt's leukemias, things that I don't think you need to know about. Really, you need to know that B cell ALL is the most common type of leukemia and cancer you're going to see in kids. So with that, brain break before we get into management of things. So questions about that? It all makes sense? Seems reasonable. Have I said anything offensive? It's been a while. I've been out of pediatric residency for a long time. And so what I really tried to do was not come in with a like academic half day as the opportunity for subspecialists to tell you everything you do wrong. So I hope to achieve that. Okay, how do I keep them from dying from their leukemia before I hand them off to somebody else to deal with? Next topic. Does it feel topical or not topical, but like okay, so this slide was inspired by being out of a tertiary care center and needing to transport people places. Because realistically, if somebody comes in and they have an emergency here, you consult PICU, and then PICU whisks them away, and you see them if you're on your PICU rotation. So how do I keep them from dying while I'm arranging transport to another center? So you are urgently called to the emergency department in your hospital to see a 16-year-old who came with abdominal pain and nausea. That's why he came to the hospital. He also had a fever. He was also mysteriously covered in bruises. And his initial blood work was done. He had a white count of that, the hemoglobin of that, platelets of that, differential of that. So what's the problem? Yeah, okay. Be more specific. Yeah, or we call this hyperleukocytosis. I hate when people ask read my mind questions. What complications could he be at risk of? This is not an exhaustive list. I don't want any picky people to be like, what do you mean by that? Just tell me what you think. A, B, or both? Both. Okay. Why? Let's get into that. So hyperleukocytosis is defined as a white count over 100. That being said, most of your problems are going to occur at white counts over 200. Okay, and it's highly lineage specific. So like, if you see somebody who's not dead and has a white count of 800, they probably have ALL. They're tiny. The blasts are tiny relative to AML. They also don't like cause DIC. They don't release like, I don't know. They're not that sticky. It's vibes, not real life. But so the complications of hyperleukocytosis, stroke, pretty rare. Haven't seen it happens though. It's from leukostasis. Respiratory failure, again, pulmonary leukostasis. Blood is slow when it's full of white blood cells. And then the cardiac problems can come from a variety of different places. But really, when I think of hyperleukocytosis, I think of hyperkalemia, and that's where I come up with arrhythmia. So what's your next best step in management? Whoops, I lost my train of thought, so I'm just going to give that one to you. Fluids. Very safe, reasonable option. Lots and lots and lots of fluids, far above what you would normally give somebody. And you're basically just trying to flush all the toxic cancer stuff out of their body and like lower a bit of that hyperviscosity by diluting some of those white cells. I think the thing to keep in mind with hyperleukocytosis is it's not a static process. You have cells that are actively dividing really quickly. So if you are, while you are like arranging for the things they need, the problem is getting worse. So this is another reason to get fluids, because you're trying to like slow things down a little bit by like diluting the concentration of their white cells, helping them pee out problems we'll talk about in a minute. But this is fun. A few hours later, he's like, I feel really out of breath and it's hard for me to finish a sentence, and particularly when I'm lying flat. He's flushed. He's got facial edema. He looks like that. What problem are we maybe dealing with? Mediastinal mass causing SVC syndrome. SVC syndrome. So like distended neck veins or chest veins, or I guess arm veins. I haven't noticed that before. Worse when lying flat, getting worse with your fluids, headache, because you drain your brain through that vessel, among other things. Honestly, haven't seen it much. I can think of one kid with this. So even though we see plenty of these, which are what? That's what a mediastinal mass. It's not the heart doing a handstand, it's a mediastinal mass. It's there. Most commonly, if you're seeing this, you're seeing T-cell ALL in the context of this kid's hyperleukocytosis. It can push on things. So our strategy is to elevate. Why did it do that? Elevate the head of the bed. And then there's a whole CHIO has a whole pathway for this, that like PICU consult, anesthesia consult, maybe cardio too. Outside of in the community, really you want to do elevate the head of the bed, evaluate for things like SVC syndrome, give lots of fluids, but if they have SVC syndrome, you have to balance that, and that requires help. You need help to do that, so you need to ask for help from somebody who either works in intensive care or an oncologist, but you need some help. An echo is helpful. This is an example of very mild airway compression. It can get worse, but that's what the CT helps you with. It gives you an idea of the degree of airway compression. I skip over a lot of physical exam stuff, but spider, short of breath, stuff like that are all relevant. You want to avoid lying flat, and you want to avoid sitting. Initial blood work showed this. What's the complication we're worried about here? Tumor lysis syndrome. So everybody here has probably at least heard the word tumor lysis syndrome because we said it a minute ago. Very simple problem. Not adrenal. It's not like adrenal trace. It's a very simple problem. You have a lot of cancer cells, which when they die, they spit out stuff. They do it in a disorganized way. Normally, your cells die and they keep everything like enclosed in little vesicles. When these cells die, they die messy. And so what happens is the things that are normally high inside your cell and low outside your cell get released, and then your serum levels of these go up, and you get complications. So I always remember it as like 3 highs and a low. So if you can remember the electrolyte problems, you can think 3 highs and a low, but there is a physiologic reason for these things. So potassium, the intracellular concentration of potassium is like 150. The extracellular concentration is like 5. So if there's a lot of that in the cell, it gets released. Phosphate, uric acid both come from DNA. These things are just constantly dividing, and so they're full of DNA, and there are like billions and billions of them. So as they die, your body like metabolizes those nucleotides, and it makes uric acid, and you make phosphate, and you are supposed to reuse that phosphate. But when you release phosphate in large volumes into the serum, it'll bind calcium, and you get calcium phosphate, so then your calcium goes low. There is a reason behind this that is basically just your cell broke open, released a bunch of things, and then problems ensued. These problems lead to renal failure as a complication, and that kind of makes everything worse because your kidneys are the main way you get some of these byproducts out of your body. And so you get renal failure as a product of 2 things. One, the uric acid, which crystallizes, that's the gout thing, but it does this in your kidneys, and then the calcium phosphate crystals. And when you end up with an acute kidney injury, it affects your body's ability to excrete things like potassium. It also drops your calcium. Both of those things can make it hard for your heart to reliably contract. So people have died from tumor lysis syndrome while we're trying to fix their tumor lysis syndrome. And you may do everything right, and somebody has a cardiac arrest. Like it's not something you can always prevent. I share this just because it's there. There is a definition of what tumor lysis syndrome is. It's 2 of these things, and then some clinical symptoms, which I find not that helpful because one of them is cardiac arrest. Another one is seizure, and a third one is acute kidney injury. The management is lots of fluids. Allopurinol and rasburicase, people get them sort of sometimes. I don't know if they get confused or not. Sometimes they're confusing. Allopurinol, the enzyme that prevents, the medication that prevents you making more uric acid. Rasburicase breaks down the uric acid you've already made. So if your uric acid is like 100 and you have hyperleukocytosis, allopurinol is great. If your uric acid is 800 and you have hyperleukocytosis, you have to do rasburicase. And I can't give you an exact threshold at which, above this threshold, rasburicase is good, and below this threshold, rasburicase is not indicated. It's context dependent. So if you see somebody who has no blasts and an LDH of 300 and their uric acid is 370, you should not give them rasburicase. If you see somebody who has 300 blasts and their LDH is 6,000, you should give them rasburicase, almost regardless of what the uric acid is. Expensive and not indicated. Yeah, expensive and not indicated. That's the short answer. Very rarely, if people have G6PD deficiency, you can precipitate a hemolytic crisis, which makes your life more difficult. I would never wait for a G6PD level to decide whether or not to give rasburicase, but it is one of those meds that can trigger a G6PD crisis. Aluminum hydroxide, it's on there. You eat it. It binds phosphate. I find it boring to talk about. you should repeat blood work because this is dynamic too. This can get worse while you're trying to fix them. And then don't fix their calcium unless you need to, which means you need to do an ECG. Find somebody who can read it, not me. Oops, I forgot to animate this one too. Transfusions. Don't give red cells if they have hyperleukocytosis unless somebody tells you to. Why? Because their blood is thick and sludgy. Platelets are fine. Platelets are tiny. They don't meaningfully increase blood viscosity. Red cells increase your hematocrit. That can make things a bit more slow. Can I point you to a study that proves that if you give red cells, you're going to give somebody a stroke? Nope. Probably mostly a theoretical risk. However, if you're dealing with somebody who is like hemoglobin 55 and they're fine, you don't need to transfuse them just because they're below 70. That would go based on symptoms. If you're going to send them to surgery or something, then you need to do that and do that in a limited way with help. But the thing I wanted you to take from this slide is don't automatically give red blood cells if they have hyperleukocytosis, even though their hemoglobin is low. If you are going to do it in a limited way, which means like 5 per kilo, 10 per kilo, like fix the problem, not the number. Okay, brain break. This part, if you don't have any more brain space for this is the last 10 minutes of the talk. This stuff is more just things that I know that you guys don't really need to know, but sometimes helps. So the way I put this is like, you're going to transfer somebody to a tertiary care center after diagnosing them with leukemia. They have a lot of questions, and sometimes it's nice to be able to tell them something that's not just you'll talk to oncology when you get there. There's a limit to how much you're going to be able to tell them, but it is helpful to have an idea of what like treatment looks like. So while you were seeing all those other patients, your 3-year-old had his flow cytometry resulted, and he has B lymphoblasts. Concern yourself not at all with the CDs. That's just what you're going to see in a flow cytometry report. But basically, it will tell you what type of blasts you're dealing with, what procedure needs to be done for treatment can start. LP, lumbar puncture. Why? CNS staging. Okay, what's steroid pretreatment? This is where we give steroids before we start their actual protocol therapy, often done by accident because they came in with a cough and we were like, asthma, dexamethasone, and then they came a week later and they had leukemia and we're like, I really wish you could do that. Life happens. Sometimes you have to do what you have to do, but you will encounter sometimes these patients in the hospital where they'll have a white count of 350 and everybody will be like, can we start them on steroids? And we'll be like, no, you can't, wait. And that's because if we give steroid pretreatment, we often have to assume that your white blood cell count was higher than what it was when you came in, which means like, if we use 50 as a cutoff and you're 48 and we gave you steroids, we kind of have to assume you're above 50. When we do that, we upstage you, which means you get more intensive therapy. When we do that, your outcomes are the same. So you don't do any worse than the people who didn't get steroid pretreated, but you often need modifications to your therapy, more IT chemo, more IV chemotherapy. And so we try to avoid doing this. Just like you try to avoid treating anybody before you get a biopsy of what they have, we try to avoid giving steroids. The other thing too, is if you don't know what they have, AML versus ALL, steroids don't do anything for AML. They don't work. So you wouldn't use them. It wouldn't help you. Staging for leukemia is risk stratification. So patients will be like, what stage am I? It doesn't work that way because it's not a solid tumor. It's kind of everywhere in your body. It's based on, and this is leukemia in general, some of them stratify based on age and white blood cell count and presentation. Often the genetics, good and bad risk genetics come into play. Often sanctuary sites that are hard for chemotherapy to get into. So the CNS, the testicles in boys. The most important factor is your response to therapy, and that can be generalized to most cancers. Prognosis often goes hand in hand with how you respond to initial therapy. And then the lineage, and by that I mean like B cell is good, generally. T cell is not great, and AML is not great. That doesn't mean that one is curable and one is not. It means that treatment intensity gets dialed up substantially if you have a high risk leukemia. CNS involvement, all I want you to take away from this is if you have enough CNS disease, we actually will radiate your brain as part of your chemotherapy, which makes you not smarter. And so one of the reasons we really avoid steroid pretreatment is we want to avoid this awkward discussion of like, have to radiate their brain. There are good and there are not good cytogenetics, and you don't need to know them, but they're there if you're curious. And your response to therapy is a currently flow cytometry-based test on day 29. This is the same for ALL or AML. We do this on day 29. Very useful for ALL therapy for understanding how you are going to respond to further cycles and use to response adapt your treatment after that point. But basically, this is a test we do where we look at the bone marrow and we say, using a test sensitive to roughly 1 in 10,000 cells, we don't see any leukemia. That's different from saying there's no leukemia there. Prognosis for ALL is generally good. I feel you know this. It has gotten gooder over the years with incremental kind of changes in treatment. And that's what research is supposed to do. And that's why we have so many kids on study. And that's why we have so many studies open and why we frequently consent people for study. Because the only way you got from, 1968, 10% of people survived to now 90% of people survive is through research. You will be familiar with the best risk group. They're the cutest patients we diagnose with cancer. They're all toddlers. Treatment duration for the acute ones and everybody with ALL is roughly 2.5 years. The intensity varies, but it's about 2.5 years of treatment in total. That is not 2.5 years in hospital. That's 2.5 years of taking some form of chemotherapy. 8 months of it is like bald, and then the other 1.5 years you have hair. That's how I describe it to families. Have you heard of blinatumomab? Okay. Blinatumomab is a drug. It's different than chemotherapy. It's immune therapy. You will see a lot of immune therapy in your careers. Immune therapy is exploding. In the course of me starting oncology fellowship, this was created in the 80s, but between me starting oncology fellowship and now, it has gone from only used in relapse cases to now used in everybody except the best risk ALL group. What it does is it overcomes one of the things cancer can do, which is hide from the immune system. So basically, there's a handshake between the T cells that are supposed to kill cancer cells that aren't doing that, and the cancer cells. It just takes them to the cancer cells and says, do your job. It has side effects. They are not lifelong side effects, unless you die, which is uncommon. CAR T cell therapy is the exact same idea, except it's attached to a living thing. So the blinatumomab is an antibody, it's not living. You have to run it for a month straight. So all these kids walk around with like backpacks, because if you stop running it, it stops being there. CAR T cell therapy is done currently at specialized centers. It is the same idea. It takes your immune system and teaches it how to find the cancer it wasn't seeing to begin with. You will see this in a lot more different types of cancer, but right now, mostly in ALL. And then very briefly, if your patient has AML, these are the kids that you probably know because you cover them on call. They spend 6 months in the hospital. They get very intensive therapy. They are bald the whole time. And they tend to have worse outcomes. And so this is event-free survival that is not relapsing. And for the best risk group, so the best risk cytogenetics AML, 70%. This is probably not including APML, which is like 85, and it's treated totally different. But like best risk AML is still not great. So in conclusion, most of the time it won't be leukemia. When it is, think of emergencies, and if there is an emergency, the initial management is probably fluids. That is all I have to say. We are at time. I left no time for questions, so you're free to go.
Thanks, Matt.
You're welcome.